Hello, hello. Good evening, everyone. Welcome to our show tonight. You guys saw I was enjoying that music. Ooh, yeah. Man, what a day it's been. Hopefully, you guys had a good week and are having a good start to your week today. Hope you had a great Monday. This is Dr. Dwain Woode. That's Wood with an E if you're new to the channel. The E stands for endocrinology. And here we help you understand your body so that you can take charge of your health, avoid complications, and live a healthy, fulfilling life. Tonight, we are continuing our talk about the thyroid. It is Thyroid Awareness Month, and we have got a show for you tonight. We're talking about thyroid cancer. What do you need to know about thyroid cancer? And I've got a special guest with us tonight. I'm going to introduce him here in a minute, who is going to come up and help us have that conversation, right? Because that's how we do it here on our channel. If you are also new, please go ahead and put new in the comments because we would love to welcome you to our neighborhood, to our family. If you have questions, please go ahead and put a Q in front of that question so that we know that is a question that we need to get to. And you'll see that I've changed it up there a little bit. I've got a new mic in front of me. This is so that we can have that kind of feel, right, of having a conversation. And just so excited that you guys are here. I think I saw Maria out there saying hello to everybody. So Maria, good evening, everyone. I think Lauren is out there. Hey, Lauren, how are you? It says, hello, Maria, good evening. And then, of course, Maria, she said, love the music. That's right. So, guys, remember that our music is powered by Epidemic Sound, right? So we're not sponsored by them, but I just love their music. If you have not seen my little clip that I put out, I think I posted it on all the social media platforms. It was just a Friday greeting, right? I was playing some music in the background. I got some good comments about it. Some people said that they didn't know I was a DJ. So we might have to do that. But yeah, so Epidemic Sound is who powers our music, and that's who we're going to be listening to tonight. Maria saying hi to Lauren. Love to see your name. Lauren said, I had to miss last week, but caught the replay. Always a lot to learn each week. Glad that you got that, Lauren. And that actually reminds me, if you guys missed the show, and we don't want you to miss the show, go ahead and get on the replay. And, of course, let us know when you do that. Just comment and, of course, share that. And then, woohoo, we've got Blind Guy, his wife, and their life who are in our in our show today. And I hope, Lakita, that you saw that I used your quote from last week. We posted it on LinkedIn. We posted it, I think it was on Facebook, several of our social media platforms. So glad that you are here with us tonight. So guys, thyroid cancer. So thyroid awareness, we've been talking about hypothyroidism. We talked about synthroid last week. And tonight we're talking about thyroid cancer. So thyroid cancer is a common endocrine cancer, right? The most common cancer that we see around the country is lung cancer. But endocrine is one of the most common that we see within the endocrine, thyroid cancer, within the endocrine system. And tonight we're going to have a discussion about it, what you need to know about thyroid cancer. So go ahead, if you have not done so right now, go ahead, send to your family, to your friends. Go ahead and share this, like it, right? Put it out on your social media platforms so that people can be tuning in for it. So thyroid cancer, common. We're going to talk today about the evaluation of a thyroid nodule leading to thyroid cancer, and then ultimately, how do we follow that? And to do that with us, I've got a special guest. Now, this guy is a colleague of mine. Whenever I have a question, right, I pick up the phone, I send him a text, I say, hey, what can you help me figure this thing out? So very smart guy. This is Dr. Ankur Jindal. So let's go ahead and just bring him up. Ankur, thank you for being with us tonight.
Thank you, Dwayne. Thank you for the very kind introduction. Now, this goes both ways. Anytime I have a question, I reach back to Dwayne as well.
Well, thank you. That's kind for you to say. So he is with us. He's one of the endocrinologists here in town. There are actually what, five of us, six of us?
There are five of us.
Five of us, right? So five of us here, and I want to say to people who are listening that as part of my practice, as I go through the day, as I've been here in town, there has been all of them have been so gracious, right? In helping, in answering questions, and what I like about the group is that we can bounce questions off of each other, as Anchor says. So thank you for being here tonight. So we're going to be talking about thyroid cancer. So tell us, who is Anchor Jindal? Tell us a little bit about yourself.
So, like you, Dwayne, I'm an endocrinologist, but I'm not a dancer and I'm not a singer. And I'm not a showstopper like you. You know, within endocrinology, I have a special interest in thyroid cancer. So a lot of my practice is thyroid cancer, and I see full spectrum of patients from the beginning, from somebody having a thyroid nodule, evaluating them for thyroid nodule, and doing the biopsies if needed, and then treating advanced thyroid cancers as well. So that's on the professional front. And on personal front, I'm a father, I'm a husband, and I would like to say I am somewhat of an athlete, very interested in staying healthy. Fitness is very important to me, and that's pretty much it.
Yeah, I mean, I was over by him. Was it this week or last week?
This week. Yeah.
And yeah, he took me down and showed me his gym. I'm gonna have to get one of those things because I could see now why he looks the way he does, because he gets up early in the morning and he's on that machine. So yeah, so you are a health buff. So, well, let's jump right into it. So we're going to talk tonight. We're going to kind of walk through. We're going to pretend we have a patient who is coming to us. We're going to walk them through the evaluation process and kind of talk through it so that the people who are listening can get a sense of the evaluation, the treatment, the management of thyroid cancer. And guys, if you have questions, once again, go ahead and put those in the chat with a Q, and we will get to those as we get through the conversation. Okay, so I guess the first thing is, how does someone show up in an endocrinologist's office? What even brings them there as it relates to thyroid nodules and thyroid cancer?
Oh, am I supposed
Oh yeah,
to
that's a
answer
question for you.
Okay, that's a question for me.
Yeah.
Okay.
So how does someone get into Dr. Jindal's office?
So many people who come to my office, either they have a very good primary care physician who touched their neck and felt there was a growth in the neck, and subsequently either they did a neck ultrasound or they decided to send them to me. Sometimes there are patients who have experienced some pain in the neck or some discomfort in the neck, or one of their family members felt there was a growth that they noticed, and subsequently the patient ends up coming and seeing me.
Okay. So either the physician felt something, there's a family member who spotted something, and they show up and you're doing an exam, or they show up with, I'm assuming, with an ultrasound that says, hey, there's this lump there. So let's pause there before we jump into the thyroid cancer, and let's talk a little bit about thyroid nodules, which are pretty common, right?
Right.
So if depending on which study you look at, they could be anywhere from 1.3% to 15, sometimes 20%, right?
And they tend to be more common in females as opposed to men. And also, as the age increases, we tend to see more and more thyroid nodules.
Okay. So as we age and female gender, some more nodules. Now, it seems like we're seeing a lot more nodules, right? And everybody's saying that. Why do you think we're seeing so many more nodules? Are we just developing more?
It is not clear whether we are developing more thyroid nodules or it is that we are just more aware of it physicians, patients are more aware of it, and they're doing more testing, and more people have access to medical care, because of which many nodules are detected, maybe even at an early stage.
Ah, okay. So we're doing maybe more testing, and perhaps we have even more sensitive equipment, maybe.
That's true. That's very right. Yeah.
So the resolution is a lot better, so we can find things that are much smaller. So thyroid nodules are out there, and I usually tell people when we think about thyroid nodules, we divide those into basically two categories. So things that are less than a centimeter, and then things that are 1 centimeter or bigger. And what do we do with each of those? Smaller ones or bigger ones? What do we do with them?
So typically a smaller nodule, we would want to monitor it or observe it over time unless there are some very high risk characteristics seen on ultrasound. Now the bigger nodules, unless you are fairly certain that this is not cancerous, you want to do a biopsy on that nodule.
Okay, so bigger ones, if there are any characteristics that are concerning, and we won't go through all of those here, that maybe that's a different conversation, a different show, but whether there's posterior shadowing, whether there's calcifications and all those type, or regular borders and so forth. So we find this nodule, we decide that it is large enough or concerning enough, and so we decided we're going to do an additional evaluation. Let's assume that we already have the ultrasound. And so what kind of evaluation do we do on that nodule?
So if you have an ultrasound, now first thing you want to see is, as Dwain said, you need to look at the size of the nodule. You want to look at the margins of the nodule, see if it is very regular or irregular. You want to see if this nodule has a lot of fluid. The nodules which are full of fluid typically tend not to be malignant, and you want to look for calcification, and this calcification is deposition of calcium, which can be small deposits, microcalcifications, or these can be large deposits or macrocalcifications. You also look and see what kind of margins the nodule has, whether there is some eggshell calcification, which is the border of the nodule, whether it is calcified or not.
Okay, all right. Now I'm I'm gonna pause here for a second because I'm looking in the comments. And hey, G Albert, how are you doing? I just scrolled back and I saw your message. And G Albert, I'm gonna put it up here for a second. He says, "Where anatomically is the thyroid?" So we just kind of jumped right into the middle of the talk, huh, G Albert? So he's like, "Hey guys, wait a minute. Let's back up for a second. Where exactly is the thyroid?" So if you imagine me with a bow tie, that's where the thyroid would be. It sits right at the base of the neck. Part of the thyroid may sit below the clavicle, and part of it above. It's connected through the middle with a little thing called the isthmus, and it kind of wraps around the neck, right? So that's anatomically where the thyroid sits. And as we talked about last week and the couple weeks before, the thyroid is responsible for energy regulation, right? That's its job. And so it is responsible for all the things in your body that require energy. And so it really is kind of the regulator of energy. And if we don't have a working thyroid, then things that need energy don't work well. So we can have hypothyroidism, we can have hyperthyroidism, and then the third category of things that we can have are thyroid nodules and thyroid cancer. Basically, so those are, if you think about the thyroid, those are the three things that happen, right? Either it's not working enough, or it's working too much, or it has a lump or bump in it, and then we're evaluating. So, so I just wanted to, I thank you for saying that, G. Albert. And so, yeah, so back to it. So we've got this nodule, we're looking for these characteristics, and we decide that we're going to do further evaluation, and that's usually in the form of a fine needle aspiration, or FNA. So, Dr. Jindal, walk us through, what are we looking, when we do an FNA, what are we looking for?
So the reason you want to do an FNA is to see if this nodule is malignant, cancerous, or it is non-cancerous. Now, when you do a FNA, what you really want to see is that there is no cancer, but your diagnosis can come back, it is cancerous, it is not cancerous, or the FNA was non-diagnostic. Non-diagnostic means that there was not enough sample or enough specimen for the pathologist to make a diagnosis. Now, other than this, there are three more categories which have different risk of thyroid cancer. So there is atypia of undetermined significance, follicular neoplasm, and you have a nodule with risk of thyroid cancer. So based on different categories, you have different risks. Now, some categories have a risk of about 5 to 15% of the nodule being cancerous. In some categories, it can be about 60 to 65% risk.
So let me get this straight. So we send the patient, they get a biopsy, and the biopsy result comes back as one of these things, right? So one of these categories, and the categories have a risk that is associated with it. So, for instance, if you get and this is just, if you get a particular category, then we can say to the patient, hey, that category has such and such a risk of having malignancy. So you can really have a conversation with the patient and put that into perspective for them as they're thinking about their particular case.
Right.
Is that what I'm hearing?
Right. That's exactly right.
Okay, good. Sorry, go ahead. You were going to say something.
Go ahead, Dwayne. Go ahead.
And so we've got this category. It comes back, and guys, as you're reading, you may see what's called a Bethesda category. That's the biopsy result. And Dr. Jinder, let's assume that we get something back that says that the risk of cancer, that it's not cancer. Let's say get a category 2, which is the one that says non-cancerous. How do we, before we get into the cancer ones, what do we do with that patient? So they've got a risk now that we've given them. The biopsy comes back and says it's not cancer. What do we do with them, and how do we follow them?
See, when a diagnosis comes back non-cancerous, then also there is a slight possibility this could be cancerous. Now, that possibility depends on the ultrasonic characteristics of the nodule. If a nodule is very large to begin with, there is about 10% chance that it could be cancerous, that you had a false negative test result. This can happen because when you took the biopsy sample, you did not get sample from where exactly the thyroid cancer is. In a nodule, there can be a small portion which is cancerous, or the whole nodule can be cancerous. So if you have a nodule which has a very small portion which is cancerous, and you do a biopsy, you may get a result saying that there is no cancer. So an endocrinologist or the physician evaluating the thyroid nodule has to look at the ultrasound pictures, and even before they do a biopsy, they have to make a decision whether this could be cancerous or the likelihood of cancer is very low. There are certain cases where the biopsy will come back non-malignant or non-cancerous, but the nodule on ultrasound looks such that you are fairly certain this is going to be cancerous. And if that is the case, sometimes you will want to have the thyroid taken out or part of the thyroid taken out. The other option will be to repeat a biopsy or do molecular testing.
Okay, so we have this nodule that we say it's not cancerous, right? Let's assume that we accept that. And that patient, we put him into a particular category, and we continue to follow that. And typically, in our practice, we would get another ultrasound, say in 6 months, and then we kind of monitor that nodule on an annual basis to make sure it's not changing significantly. So that would be a nodule that we looked at. It is not cancer. We put it into this category, and we just continue to monitor that patient, because as you point out, even though it says that, hey, this is not cancerous, there is still a small chance or possibility. And guys, let me kind of explain that a little bit to you, why that would be the case. So let's pop back up here. So if you think of a nodule as a little ball, okay? And what we're doing is we're putting a needle into that nodule to get some tissue to say that nodule, that tissue does not have cancer in it, okay? Well, if you could think of a ball, the bigger the ball gets, and you're putting a needle into a particular part of it, it is possible that there's another part that you missed. Does that make sense? I hope that makes sense. So the larger the nodule gets, right, the I don't want to say the more risky, but yeah, it is possible to have a spot where we didn't actually do a biopsy because we've biopsied somewhere else. And so when we get a diagnosis of non-cancer in a thyroid nodule, what we're saying is that for the most part, it looks like it's not cancerous, but there could be a particular spot where the cancer was that we did not biopsy, okay? And so we monitor that thyroid nodule. We monitor that patient to make sure that we catch anything that may come up, right? But for the most part, if it says it's non-cancerous, then we accept that, and that is the highest possibility that it's non-cancerous. Okay, so that's a thyroid nodule. So now we've gone on and we've said, hey, we're going to biopsy this thing. It comes back and it says, hey, it's cancer. Okay, so let's now walk down that path. Before we get there, let me look in the comments and let's see who has joined us. So let's see, what do we got here? Well, G. Albert, we said hi to you earlier because we answered your question. But hey, man, how are you doing? He says, hello, Dr. Woode. Hey, man, glad that you are here. Of course, Maria is continuing to greet. And Lakita, she said, thanks for using it. Wow, now I'm here ready to drop another gem. Come on, Lakita, we're waiting for your words of wisdom, yeah? So Lakita, we used one of her thoughts last week in our post. So she was really, she dropped some wisdom on us. And then, of course, G. Albert, where anatomically is the thyroid. Hey, Sadie, how are you? Welcome, welcome, welcome. Glad that you are with us tonight. Let's see, Blind Guy, he says, good to hang out with you in all the best places. He said, this is a good show already. She said, you know what? I almost motioned to my son to get me a bow tie when I was explaining that, but I didn't do that. She said, put on a bow tie and look in the mirror to see the anatomic location of your thyroid. G. Albert, thank me later. Maria said, haha. G. Albert says, hey, thanks, Lakita, Doctors Woode, Jindal. Is it an IT being one or multiple? Isn't it only in the front, the back of the neck around? Oh, okay. Yeah, so the thyroid sits at the base of the neck in the front, okay? But what I was explaining was, your bow tie kind of sticks out to the side, right? Well, the thyroid doesn't do that. It kind of wraps around the neck. So anatomically, it's kind of encircling the neck. Now, a lot of times, it doesn't go all the way, back here, right? But you have some muscles on the side called the sternocleidomastoid or neck strap muscles. And so sometimes the thyroid lobes are actually under those muscles. And you've got to kind of, when you're doing an exam, you've got to really kind of get at it, have the patient, swallow so that it moves up and down. So it doesn't go all the way back here, but it does sit in the neck.
And I will also add that there is only one thyroid. It has two lobes and isthmus, which is the central part, but it's only one thyroid.
Yes, thank you for saying that, because sometimes we think of, we use the words, the right thyroid, the left thyroid, but it's actually one thyroid with left and right lobes. So thank you for clarifying that. And let's see. Just want to acknowledge Lori Barber. Thank you for tuning in. All right, Lori, thank you also. And G. Albert, I'm going to take this question and I'm going to star it because we're coming back to answer that question here in a little bit. Lori says, hi, Maria. Yes, I'm listening. Also shared with my sisters. Thank you for doing that. We love that, guys. And then I'm going to Lakita. I'm going to star that one as well. Okay, so now let's get back. So we've got this person who we says has thyroid cancer, And now we're going to go down the path, down the road of evaluating the thyroid cancer. What do we do with it? What do we do in terms of treatment? And I think the first thing to kind of talk about is that there are different types of thyroid cancer, right, that have different risks of death and complications, so forth. Can you just list off a couple of those for us? So what's the most common thyroid cancer?
So the most common thyroid cancer is papillary thyroid cancer, and then we have follicular thyroid cancer. These are both differentiated thyroid cancers. And then we also have medullary thyroid cancer, which is relatively rare. And other than this, we have undifferentiated thyroid cancer, which tends to be very aggressive, and anaplastic thyroid cancer. Another rare form of thyroid cancer will be your lymphoma of thyroid. Now, within this broad classification, every thyroid cancer, every subtype of thyroid cancer has further multiple variants or subtypes. And I think we'll go into the details as we talk more about treatment or management of thyroid cancer.
Okay. All right. So basically, so two main categories. So well differentiated and not well differentiated. Okay. So the well differentiated ones are the most common. So papillary, follicular thyroid cancer. I think those two make up about 85% maybe. Sometimes I see a paper or a book that says 90%. Then there's medullary thyroid cancer, which is a special one that we'll talk about here in a minute. And then the undifferentiated ones, which are aggressive, and of that class, probably the one that people like the least is the anaplastic. Is that a kind of a good breakdown of it? I know there's a lot more fine details in there.
Yes, you did a really good job at describing all this.
Okay.
Dwayne, I never knew that you were such a showstopper and such a showman.
Well, we try to explain things the way we understand them. So that's what you're hearing from me. Okay, so we've got a papillary thyroid cancer, which is the most common. So let's go ahead and let's deal with that one. So we've got a thyroid cancer, and the biopsy says, hey, this is cancer. Most likely, well, I guess we don't know yet that it's papillary, but most likely it's going to be papillary because that's the most common. What do we do with that patient after the biopsy that says it's cancer? Where do we take them? Where do they go? Who sees them next? And what do we do next?
So once you're diagnosed with thyroid cancer or the biopsy says that you have thyroid cancer, the next thing to look at is how big the nodule is, because that helps you determine whether you're going to have part of your thyroid taken out or all of your thyroid taken out. The surgery is typically done by a head and neck surgeon. And now the decision regarding what kind of surgery you're going to have is made in collaboration and depending on what a patient's preference is and what the comfort of the physician is and what kind of facility is available in the area where you are, what kind of monitoring can be done.
Okay, so lots of moving parts there, but ultimately we're going to surgery.
Right.
Is that correct?
That's correct. There is an option of not doing the surgery as well. If the thyroid cancer is very small, one may choose not to do the surgery and observe it over time and see how it is going to change and how it is going to grow. Now, this can only be done if you have somebody, a physician, who is willing to monitor it, and if you have enough support from the radiology department or radiology to do adequate ultrasonography or monitor the cancer or nodule very closely.
Okay. So there is the option of not doing it, but you've got to be, if I'm getting you right, you've got to be in a place that has the facility to do that.
Right.
Okay. All right. So has the facility, has the resources where we can do multiple imaging, follow up, and so forth. But let's assume that we're going to do surgery. So we go to surgery. Typically a head and neck surgeon, although there are some other surgeons that do thyroid cancers as well, or thyroid surgery, I guess I should say. Let me put it that way. So we have surgery. And most of the time, the surgery, the time, I mean, you're maybe 1-2 days in the hospital, if that much. They make a small incision in the neck. They take that thyroid out. And you actually said something there that I want to come back to. So how do we decide whether to take out the entire thing or part of the thyroid?
Excuse me. So, whether you're going to take out the whole thyroid or part of the thyroid is decided based on how big the cancer is, what is the size of the nodule, whether there is involvement of any lymph nodes before, whether you know about any lymph node involvement before you do the surgery or not. And then it also depends on preference of a person. Now, some people will decide to do partial thyroidectomy or just take part of their thyroid out because they don't want to take thyroid hormone replacement after the surgery. Less than 50% people who have part of their thyroid taken out will need thyroid hormone replacement after partial thyroidectomy.
Okay, so partial thyroidectomy. So of course, the people who have them all taken out, they're going to be on thyroid replacement. Partial thyroidectomy, some of those people will be, and some will not. So we've taken the thyroid out. We have this patient on thyroid hormone. Is there anything else that we've got to do post-surgery for not for the management down the road, but for the treatment of the thyroid cancer at that time, other than surgery?
So some people will need radioactive iodine ablation. Some people do not need radioactive iodine ablation. There are different reasons why radioactive iodine ablation is done. Now, the important thing to know is that radiation or radioactive iodine ablation can only be done if all of the thyroid is taken out. If only part of thyroid is taken out, you cannot have radiation done. Now, there are multiple different reasons why radiation is done. So one is remnant ablation. Remnant ablation means that whenever thyroid is taken out, to save a lot of important structures in the neck, like laryngeal nerve, the nerve that supplies your voice box, a lot of the blood vessels, some thyroid cells are left next to those important structures. And remnant ablation is done to take care of those cells. Other than that, radiation can also be done if a physician thinks that the thyroid cancer was relatively aggressive. There is a good chance that some lymph nodes were involved, and the risk of thyroid cancer coming back is relatively high. In those cases, you will do a relatively higher dose of radiation to treat what we call occult malignancy. So thyroid cancer, which is there somewhere, but you don't know where it is. And then the third reason to do the radiation will be if you know that there is thyroid cancer somewhere, you know where exactly it is, and you're trying to treat it.
Wow. So the radiation really is to try to kill any remaining thyroid cells.
That's right. That's
Okay.
one of the purposes of radiation.
One of the purposes. And you mentioned there that the remnant ablation, and sometimes I think people, and rightly so, they think if I've had a total thyroidectomy, right? So when you use that phrase total thyroidectomy, that means that you took out the total thyroid. So if you took out the total thyroid, why should there be any thyroid left? And what you just described is that there are certain structures in the neck that are so sensitive and so valuable that we basically cut the thyroid out and may leave a layer of cells along that structure, like nerves, vessels in the neck, so that we don't damage them. And then now we've got to go back and do radiation to kill those cells that may be left. Wow. Well, guys, let's take a break right here, and let's change paces for a minute, and let's talk a little bit about our channel. We love the fact that you guys are here, that you are with us, that you're joining us. We love this community that we're building. If you've not already done so, if you've not talked to your friends and your family and coworkers about our channel, right, and about what we're doing, please do so. We are on LinkedIn, TikTok, here, of course, on YouTube, our Twitter feed. And then if you'd like to support the channel, buymeacoffee.com. If you want to see more, if you want to see more, what? If you want to see more, then join us every Monday night, 7 o'clock, right here on YouTube. We've got our TikToks that come out on Friday. And this past week, you may see those have come out. They come out in lots of different times, right? So we're playing around with the times to see what's best. And then, of course, every day, our Twitter feed puts out recipes. We talk about different foods. We talk about exercise. We talk about sleep. We talk about stress. So things that we want you to know and things that are important in our lives as we move forward. So once again, if you've not already done so, go ahead and hit us up on our social media. Like this channel, subscribe, and this one. Yep. And so Dr. Charmaine Woode launched her business, and she is our sponsor for tonight. CharmaineWoodeMD.com. Weight loss coaching for women who want to live longer and be healthier, right? Lots of different options there. There are group and individual coaching, and we're just so excited that we are able to partner with her as she talks to people about reshaping. You guys see that there? Talks to people about reshaping their life, right? So she's a reshape specialist, and we are just so excited, so happy that she has been a part of what we do. If you did not catch us, that was, 3-4 shows ago where she was our guest, and we talked about the gifts that we give ourselves. That was through the Christmas season, okay? So the gift of self-care, right? The gift of forgiveness, all of those things. Please go ahead, share with your family and friends. And Maria, if you would, just go ahead and drop that link in the chat for me so that everyone can have that, right? So Dr. Charmaine Woode, thank you so much. All right, and we are talking with Dr. Jindal. We're talking about thyroid cancer. So Anchor, so we've got this patient and we've done surgery. We may or may not have done radiation. And so we are post-surgery now, and we're getting into kind of follow-up, long-term maintenance for this patient. What does that look like for this patient? Yeah, I think you're muted there.
Oh, sorry.
There you go.
So, when we look at long-term maintenance, there are certain goals. One is you want to reduce the risk of thyroid cancer coming back. The second is to diagnose the cancer or to find cancer as soon as it returns. So to reduce the risk of thyroid cancer coming back, you have to make a decision whether you need to do radiation or not. And the second thing is you want to do what is called TSH suppression. Now, TSH suppression is suppressive therapy with thyroid hormone replacement. And regarding to monitor whether the cancer is coming back or not, there are a few things that are done. One is you need to do a good clinical neck exam to feel for any lumps or bumps that appear in the neck. Now, this is done both by the physician on scheduled visits and also by the patient at home at certain intervals. In addition to that, you do periodic neck ultrasounds and any other imaging that is required. This may include a CT scan of the neck or whole body iodine scans. And very rarely, you may also need a PET scan. Now, other than this, you will also monitor with thyroglobulin, which is considered the tumor marker. Now, thyroglobulin is a protein that is made by normal thyroid tissue as well as thyroid cancer. So if you have thyroid tissue, even if it is not cancerous, your thyroglobulin level is going to be high. And if you have not received the radiation, or if a patient has not received radiation, then also their thyroglobulin is going to be detectable.
Okay, all right. So we do surgery. We may or may not do radiation, right? But let's assume that we do. And as we said, the radiation is to kill those residual tissue, the residual cells that may be there. And then we suppress the TSH, right? Because we don't want the thyroid stimulating hormone to stimulate any cells that may be remaining, right? And that's how I kind of explain to people. And then we monitor this thing called thyroglobulin, basically a tumor marker, because if the tumor marker goes up for any reason, then we've got to go looking to see if there is something there for us to find. Now, let's assume that, our people who are listening, they go to their doctor and says, hey, I check my thyroid, right? And they don't have thyroid cancer. And somehow the doctor checks their thyroglobulin and it's elevated. Should they begin worrying?
So if the thyroglobulin is elevated in a person who has full thyroid, there is no reason to worry. In fact, if the thyroglobulin is not elevated, there is a reason to be concerned. And typically, there is no reason to check thyroglobulin in a person who did not have thyroid surgery or who does not have thyroid cancer.
Okay. So it is the marker of thyroid cancer, I guess, recurrence if your thyroid has been taken out, and particularly if you've had ablation, then that number makes sense. Because right. if it's low, that means, okay, there's nothing there. And if it starts to climb, then that means that, hey, there's something that we've got to go looking for. Okay, good. I love that. All right, so that kind of walks our patient through an evaluation, thyroid surgery, the treatment for thyroid cancer, and then, okay, this is now long term. Now, I guess the question that I have here is, who follows that patient? I mean, is that the surgeon? Is that the primary care doctor? Is that the endocrinologist? Do they need to be followed? Or is this just, okay, you've got the surgery, you had the radiation, you're on suppressive therapy, and you're good?
So the patients need to be followed by an endocrinologist. They need to be followed fairly closely, and few of the reasons are: one is to monitor for reoccurrence of thyroid cancer, to make sure that surgery and the treatment was appropriate and there is no remaining thyroid cancer, and also to make sure that the patient gets the right amount of thyroid hormone replacement.
Okay, good. So right amount of thyroid hormone. All right, so let's jump back here and let's see who has joined us. Let's see. I think we talked about that already. This is why I love when Blind Guy and his wife comes. Corey, you and Lakita always, this is my cheering section right here. It said, Dr. Jindo, please remember that Dr. Woode is being modest when he says E is for endocrinology. The E is in Woode is for excellent explainer.
I will totally agree with that.
So Lakita, you're my cheering section. Okay. Let's see. So we got another question from G. Albert that I'm gonna go ahead and star that, G. Albert, and then so let's see. So why don't we do this? Let's go ahead and let's grab some questions. How about that? Let's see. Let's back up. All right. I don't think we've seen this one yet. This is from Lakita, from Blind Guy, his wife, their life. It's like a bow tie without the straps, whereas it's on the front, like a kid's clip on G. Albert. When I worked in surgery, I never got a chance to see thyroid surgery. Yeah, G. Albert, I think I saw you somewhere, and you were wearing a bow tie. now that she says that. And Lakita says, my question, let me pull that up. For some reason, there it is. She says, my question is in regards to whole foods being a benefit to aiding in the healing of the thyroid when, partial thyroidectomy is left. if partial thyroidectomy is done, is there ever a functioning portion? So Dr. Jendo, so when we do partial thyroidectomy, is there a functioning part that's left in?
Yes, so typically when you're doing partial thyroidectomy, you're doing lobectomy, which means taking half of your thyroid out, and also a lot of times the isthmus, which is the central part of the thyroid. So, so you're left with nearly half of your thyroid, and when you're left with nearly half of your thyroid, more than 50%, for more than 50% of people that have thyroid can make enough thyroid hormone for their body's needs.
Okay.
So what I'm trying to say is that about 50% of the people who have half of their thyroid taken out will not need thyroid hormone replacement.
Wow, that is pretty good. All right, so half of their thyroid is gone, and they still have the ability to make thyroid hormone. Now, I suppose this is an argument for doing a partial in those patients that are low risk. Right, because at one time we just took everything out. Right. We took everything out and we radiated everybody, right? But we've learned a lot more about how to manage these patients, and so we are doing things that are decreasing complications, morbidity, mortality for these patients. So that's awesome. All right. So it says, since you are doing a biopsy, you are diagnosing if it's abnormal. Thyroid growth is cancerous or benign. Is the treatment the same for both radiology/surgery, or for benign, do you just observe?
So typically for a benign thyroid nodule, you're going to observe it with clinical exams by examining the neck, palpating the neck, and also by repeating neck ultrasounds. Now the purpose of doing these neck ultrasounds is you set certain parameters. If there's a certain amount of growth in that nodule over time, then you may have to repeat a biopsy to make sure that it has either a cancer was not missed previously, or that a nodule which was not cancerous has turned into a cancer.
Okay. All right. So we're watching to make sure that a nodule that was there does not become cancerous. So that's kind of that long-term monitoring for those that came back as benign, that did not have cancer in it. So let's see. Let's grab some other questions. So, what is the cause of thyroid cancer? Do we know what is the cause of thyroid cancer?
So, yeah, I didn't realize that Dwain was waiting for me to answer that question. Now, there are certain risk factors for thyroid cancer. If you had, or if somebody had radiation to the neck as a teenager or before the age of 18, if they were exposed to some sort of radiation disaster, that those things will increase your risk of having thyroid cancer. But we don't know why some people get thyroid cancer and why some people do not get thyroid cancer, unless Dwain knows about something different.
No, I think so. But I think early on, I think the same things that predispose to thyroid nodules we can list here, right? So women, the older we are, and exposure to radiation. Right. So I think those fall right in line. Now, I saw something recently, and let's just throw it out there, that there was a link with cancer, thyroid cancer in particular, with being obese.
I think obesity has been linked to multiple different kinds of cancers. Mm-hmm. I don't know if that cause has been established or not.
Okay. Okay, fair enough.
So I don't know what your thoughts are about it, Dwain.
Well, it's an interesting concept, but you're right. We are learning that obesity predisposes to lots of different cancers, and there's so many different theories and thoughts about why that is. So I would not be surprised if we do learn that this is, and it may not even be a causal relationship, but an association, right? So sometimes we can't say, well, this thing caused that, but we can say, hey, people who have this characteristics, it seems to be associated with people who have something else. And so sometimes that's the best that we can do in terms of finding a reason. Okay. But right now, we really don't have a causal reason for thyroid cancer.
So just
All right.
another thought. So in people who are overweight or who are obese, could it be that they are exposed to so many other different things, so many other chemicals either from their food or so many other medications, or they have so many other underlying conditions which are predisposing them to thyroid cancer?
Well, one of the I love that thought, right? And one of the things that we are going to be learning a lot more, right? And let's, I'm always throwing diabetes into the mix, right? So this idea of inflammation, of cytokines, right? So we don't know all that those things do, right? And so whether it's tumor necrosis factor and I'm not going to start calling them all out. That's a conversation for a different day. But the inflammatory process that is going on in the body, right? So the inherent damage that we're doing to our immune systems, right? So all of those things can have implications, whether it's cancer or other quote unquote diseases that we're seeing, right? It seems like the diseases of autoimmunity seem to be skyrocketing, right?
That's very true. And
Anyway, so you got me going down a path there for
right. And maybe very soon we are going to hear about gut microbiota leading to the thyroid cancer, the changes in gut microbiota.
That's right. Okay, all right. Let's get back to these questions. Listen. Okay. Is there a thyroid cancer test? Is there a test that people can look at, ask for to be diagnosed to see if they have thyroid cancer?
So typically, the path that you want to go is you want to have a neck ultrasound if a nodule is felt, and then have a biopsy done. But there is no specific blood test that you can do which will tell you whether you have thyroid cancer or not.
Okay, all right. So this is a physical exam, an imaging diagnosis, a biopsy diagnosis. This is not a blood test. Okay, you have thyroid cancer. We're not there yet.
Right, we are not there yet.
We're not there yet. Okay, so here's a question. Lori says, if diagnosed with hyperparathyroidism, does that put you at risk for thyroid cancer? What do you think?
So if you're diagnosed with hyperparathyroidism, it puts you at risk of being diagnosed with thyroid cancer. It does not put you at risk of thyroid cancer. By that, what I mean is that if you're diagnosed with hyperparathyroidism, there is a good possibility you are going to have neck imaging. You may find an occult nodule, which may turn to be thyroid cancer. But just because you have hyperparathyroidism, it does not increase your risk of having thyroid cancer, other than medullary thyroid cancer.
Now this is actually a good place, because I mentioned that we would come back to that one, right? So of the cancers, right? So of the cancers, that's the one that seems to be associated with a genetic familial component, and particularly, and I'm talking about MEN syndrome. Is that correct?
That's correct. Yes,
That's
yes,
correct.
Dwayne.
Okay. All right. Yeah. So that one, and I think there's a question in here somewhere, but let me. So you guys, I love our folks. So I'm gonna put this up here for a minute. So Dr. Woode, when Lakita and Corey responded with the comment, "When I worked in surgery, I never got a chance to see thyroid surgery. Please tell me that Corey didn't assist in the OR." So Corey, why is G. Albert getting on you? Why is G. Albert getting on you? All right. So the antioxidants and fiber in whole foods and their anti-inflammatory processes or properties, could help the reversal of thyroid damage. Okay. So let me jump in here and make a comment, Lakita. So yes, it is possible, and we are always talking about building the immune system, anti-inflammatories, and so forth. One of the things I do not want people to get the idea of, right? And we have not learned this yet. It is not in our literature. We have not seen it. There is currently no food and or medication that gets rid of thyroid cancer. Okay. Now there are people who talk about using different foods to manage hypothyroidism that may be autoimmune, Hashimoto's, avoiding gluten, avoiding this type of food. But we have not been able to identify any food and or quote unquote medication that will treat thyroid cancer. Currently, the treatment for thyroid cancer is surgical removal. And as Dr. Jindal mentioned earlier, that there are some cases where if the thyroid cancer is small enough, then we may opt not to do surgery, but to do what we call watchful waiting, right? Which is where you kind of monitor and make sure that it doesn't get significantly larger or problematic. Now, one of the things about thyroid cancer, guys, is that, let me pop over to this one. So thyroid cancer is a slow growing cancer. Okay. So when we're evaluating thyroid cancer, that's why when you see someone who has a nodule, sometimes, you'll say, hey, let's get an ultrasound in 6 months. Right. And if that's good, let's get an ultrasound in a year. And the reason we say that is that nodules in the thyroid grow slowly and thyroid cancers grow slowly. Okay. So there is the opportunity for doing what's called watchful waiting. And so if the thyroid cancer is small enough, sometimes the decision with the patient and the treating physician is to say that we're not going to go to surgery and we're just going to watch this with monitoring with ultrasounds. So that is also an option there. Okay. All right. Okay. So let's also, let's pull up this thing here, guys. We're going to do our thought of the day. So here's the thought for today. Here's the thought for today. Let me read it. If you believe it will work, you'll see opportunities. If you believe it will work, you will see opportunities. If you believe it won't, you will see obstacles. Wow. Right? And that comes from Wayne Dyer, right? If you believe it will work, you will see opportunities. If you believe it won't, you will see obstacles. Now, we've been talking, right, the last several months about the change in mindset. We've been talking about the ability of the mind to propel us into greatness or the ability of the mind to keep us locked where we are. And so it all comes with this idea of what you are expecting, what you believe. Anything that you're attempting, anything that you want to do, anything that you are trying to do, if there is doubt, if you are down on yourself, if you say to yourself, oh, this is not going to work anyway, or it never works for me, or I never get a chance, or I never cut a break, or I never, right? If those things are what's in your mind, that's in your spirit, then everything that you want to do, anything that you are attempting to do, you will see obstacles in the way where other people will see something that can help them get to their goal. Okay. So if you believe it will work, you will see opportunities. So the opportunity and the obstacle sometimes are exactly the same thing, but it depends on what you are looking for, what you are seeing. If you believe it, it's an opportunity. If you doubt it, then it's an obstacle, right? That job that you lost is an obstacle, but the opportunity is now you get to do something else, right? Right? That change, that move that you had to make is an obstacle, but maybe that frees you to be able to do something else. And so being able to visualize, being able to put into words in our mind, in our spirit, in our hearts, the opportunities that we're looking for is what gets us to those great things that we said that we wanted to do in 2022. You remember that, right? Setting big goals in 2022. And that's what we want to do as we move forward. That's what our channel is for, right? So we're trying to help you to understand your body, understand how things work, also the mind, so that you can take charge of your health, avoid complications, and live a healthy, fulfilling life. So, Dr. Jindal, we are so happy that you were able to be with us. Let me see. Let's back up here and let's see what we got. G. Halbert's trying to drop us some words here. He says, watchful waiting. Does that mean that there is a chance for reversal of the thyroid growth? Now, so this, I think, can answer a couple of ways. And Dr. Jindal, I'm going to have you kind of take a stab at this, and then I'm gonna jump in and say a couple of words. So he's saying, when we're watchfully waiting, does that mean that there's a chance that the growth reverses?
G. Albert, so what we are trying to say here is that we are hoping that the cancer is not going to grow very rapidly. We are not looking at reversal of growth, but we are looking at a very slow pace of growth or no growth over time, over a few years.
All right, good. So as I read that question, I'm going to make a couple comments. So as Dr. Jindal says, we are looking to make sure that we don't have any changes that are significant in the negative. Okay. So if it's a small cancer, then we don't want that to get bigger. Okay. When we're looking at nodules, right, we're also looking at those nodules to say that we don't want them to get bigger as well. And if they get bigger, we do go ahead and we biopsy those if they get large enough or if they show significant growth, right? And we're saying that we don't want that nodule to now become cancerous, right? So usually when we're doing the watchful waiting, we're not necessarily looking to see that that nodule that was there goes away. Now, I've had patients where a small, tiny nodule, we go and we get another ultrasound and it says, hey, that nodule that we saw last year, we don't see them anymore, okay? But when we're talking about thyroid cancer, when that biopsy says, hey, you got a thyroid cancer, we're really kind of looking to make sure that we're not getting into dangerous territory, okay? All right. So Lakita says, thank you, Dr. Woode and Dr. Jindal. This was fantastic. Yeah, guys. So I am so excited to have had Dr. Jindal to have this conversation with us, to explain the things that he's explained to us. Anchor, thank you for being here. And I hope that you will be back with us and we can have conversations about that. There's so many endocrine things that I want to talk about. And as you see, our viewers, they've got questions, right? And they love engaging. But thank you for being with us tonight.
Thank you. Thank you so much, Dwayne. And thank you, everybody.
All right, guys. Yeah, so always thank you for coming out. Thank you for being here. We really appreciate the fact that you guys are engaging with us. If you've not already done so, please go ahead and like us, give us a thumbs up, share this video with your family and friends. Have them to go to all of our social media platforms as well. Once again, we've got LinkedIn, TikTok, Facebook, not Facebook yet. It's coming, though. Here on the YouTube channel, Twitter, and then, of course, buymeacoffee.com. So this is Dr. Dwain Woode from Diabetes and Endocrine Wellness Center and The Lighter Way, educating the public for a better you. Once again, I hope you guys liked the music at the beginning, and let's get some music right now, and let's get on out of here. Thank you. Good night.